So I am so pleased to introduce Dr. Richard Stewart. He's a clinical professor emeritus in the Department of Psychiatry and Behavioral Sciences at the University of Washington, and he's a member of the medical staff psychology at Swedish Edmonds Hospital. He created the 6 Steps Living Will online tool to assist persons and families in creating end-of-life plans. And I'm just really excited to hear about him talking today about advanced care planning from intent to actionable orders that align treatment desired with treatment delivered. You're in for a treat. Welcome, Dr. Stewart.
Thanks very much, Dr. Cochran. Despite Dr. Cochran's supreme efforts to rein me in, I prepared a 90-minute presentation that I'll try to shoehorn into 75 minutes. I'll skim through some of the slides that are more operational because you can download them and read them more carefully at your leisure. If I don't have time for questions, despite my best intention to do so, please contact me directly. I'm profoundly committed to helping people, helping patients exercise their autonomy through advanced care planning, and I will do everything possible to empower healthcare professionals to assist in what I think is the most important humanizing medical service that we offer and what matters most to many people. One question is going to arise, and I'd like to begin by addressing it because I may not fully expand it when we get there. For reasons I'll explain, I am highly critical of the pulse and in fact will not use it. Instead, with the help of a lot of colleagues and countless patients, I developed the MOLI and the CMO. Like the pulse, both are double-sided, single-page protocols that correct many of the flaws that I think the pulse group refuses to address. I use the MOLI when time permits because it's more comprehensive, but I use the CMO when time is limited because both it and the MOLI can be customized to meet individual patients' needs, and both forms can be downloaded and edited at your pleasure. My goals today are to remind you about the importance of advanced care planning, but spend the bulk of the time on the pragmatics of how to deliver it. I'll give short shrift to the literature because, in my humble opinion, most of the studies are relatively weak and often inapplicable. And I'll give you a few examples as we go along. I hope you'll create an advanced care planning toolkit by printing references 1, 2, and 3, and any of the slides with green writing. I'd like to offer special thanks to all the members of the Swedish Ethics Committee, all the patients we have served over the last 20 plus years, and to Stephen Thielke, with whom I did much of the work that I'm going to describe. As I said, I've spent about 25 years developing this. The essence of my approach was described by a very good friend, Anatole Broyard, in his wonderful book, Intoxicated by My Illness. Anatole wrote, "I want my doctor to be one who's a close reader of illness and a good critic of medicine, one who's not only a talented physician, but a bit of a metaphysician too, one who's able to go beyond the science into the person, imagine the loneliness of the critically ill. I want him to be my Virgil, leading me through my purgatory or inferno, pointing out the sights as we go." From my point of view, advanced care planning should be an intense, collaborative contact that benefits both the patient and the healthcare professional. I consider it a real gift whenever a patient allows me to share this critical moment in his or her life. Advanced care planning was sanctioned in the US Constitution under the clauses that grant right to privacy. The 14th Amendment protected citizens' rights against state interference, and the US Code in 1983 gave patients a right of recourse if they felt their rights were violated. My co-author and good friend, Jim McDermott, was one of the sponsors of the Patient Self-Determination Act, which created the mandate that patients be offered a chance to create living wills, that the living will be recorded in their medical record, and that the living will must be respected. That has been further augmented in various federal Medicaid guidelines, and of course in the RCWs in the state of Washington and most other states. Since patients have a lawful right to create an AD and have it respected, any failure to do so risks ethical, moral, legal, and civil penalties. Think about what advanced care planning does. It helps people think about how they want to live until they die. It helps people accept the inevitable so they don't miss the chance to achieve a sense of completeness or coherence about their lives. As you'll hear, radical acceptance of the inevitable, I think, is a really core dimension of the approach that I use in working with patients. It helps patients understand the options in end-of-life care while they can still think clearly so they can choose treatments wisely. It relieves loved ones of the need to make decisions that can cause never-ending guilt. If I were able to play video clips, I would show you one of a nurse I interviewed some years ago, whose mother had died 4 years earlier without an advance directive. The nurse said that on alternate nights she has nightmares, and one her mother comes yelling at her, "Why did you make me suffer so long?" And the next night her mother yells, "Why did you let me go so soon?" Living wills protect survivors of the uncertainty about whether they respected or ignored the decedent's wishes. It also helps to avoid potentially family-destroying conflict. I've seen many instances in which siblings quarrel over whether mom did or did not want to be resuscitated, and then end up never speaking to each other again because of the disagreement. If you've delved into the area at all, you know that 70% of people say they want to die at home. And incidentally, we're going to get to that a little bit later. But 60% die in hospitals, nursing homes, or long-term care facilities. 80% say that if they're seriously ill, they'd want to discuss their end-of-life care with their provider. But as few as 7% say they were ever fully discussed. 82% say it's important to put their wishes in writing, but only 23% have done it. And the fewest of those in ethnic communities, and we'll address that issue a little further on as well. 60% say it's important not to burden their families with tough decisions, but very few ever do. Why doesn't every patient have an AD? And why isn't every AD honored? Well, there are many, many reasons. Many ADs are often vague, too long, unavailable when needed. That's true, but it's correctable using the methods we're going to talk about today. Some say that creating them is an undue burden on healthcare workers who are already overworked. It's true, they are a burden, but as I said earlier, they're also an opportunity, and they are a practical, moral, ethical, and legal necessity that can be done efficiently, and if necessary, can also delegate them to volunteer facilitators. A third objection is that ACP is a checkbox exercise. That's true if you do it poorly. If you just read off a form and say, do you want this or not? But it's false if it's done properly. Conducting advanced care planning is very impactful interpersonal process. And as I said, it really helps humanize medical practice for patients, providers, and for significant others. People also object to advanced directives as Ulysses contracts. You all remember from 8th grade classic literature that Ulysses had himself bound to the mast of his ship as he sailed past the shores where the sirens were beckoning him. Well, in fact, Ulysses may not have been able to get himself unbound, but patients can, because every decision in a living will or an advance directive can be revised as often as patients, conditions, and wishes change. A lot of people also don't do it for reasons like, I'm not trained, therefore I'm not comfortable doing it. I'm not sure it's important to offer it at all. I'm under too much time pressure to do it. Frankly, I view death as a failure or an option rather than a natural event. I certainly don't want to discuss it. I'm uncomfortable contemplating and planning my own decline. Why should I ask any patient to do it? I'm committed to avoiding contentious discussions. Incidentally, I'm sorry, I'm seeing typos in slides that I've gone over about 300 times, and nevertheless, typos have crept in, and I apologize for those. So patients say they want to avoid conflict with patients, with colleagues who disagree, or with family members who may have a different opinion. I'm going to address all of those in order to help you take action. So let's frame the issue. American healthcare does sell patients short, whether you view it as an end, a transition, or a beginning. And don't blame me, but we're all going to die. And the odds are that we'll do it only once. Since the way we die is in some way the ultimate summary of our lives, and it punctuates our legacy, it's important to do it right. Unfortunately, many patients die later than they want, others sooner. What's a good death? We often talk about it. In Western cultures, a good death is one that preserves personal dignity, is free from excess pain, avoids harmful treatments that delay death at high personal, social, or economic cost, allows for the achievement of spiritual, emotional peace of mind, and allows families to avoid unnecessary stress. But this is not universally accepted due to religious and cultural perspectives. For example, I have worked with some patients who want to endure as much pain as they can, because they believe that the more they suffer as they die, the closer they will be to identifying with Jesus' agony on the cross, and the quicker their entry into heaven will be. So be very careful to assume that patients want what you think is a good death. We really have to help patients articulate their ideas and then respect their choices. I think it's best to look for deaths that are good enough. Now, everybody has an AD without knowing it. This is due to an inherent, omnipresent, under-the-radar bias in healthcare that treats death as an enemy or an option to be avoided rather than an inevitability that can often be managed to some extent. Among its very many flaws, there's a bias evident in the title of the widely used pulse, Portable Orders for Life-Sustaining Treatment. Frankly, personally, I don't want an order for life-sustaining treatment. I want an order that reflects the kind of treatment I want, but the title is highly biased. In fact, the majority of those asked want comfort versus aggressive care when the quality of their lives fails to reach a point at which living is viewed as more problematic than dying, and they want to use their AD to limit rather than expand their treatment. I mentioned earlier that I'm going to not pay a lot of attention to the literature. Here's a study that I like because it confirms one of my biases. It was a review of treatment of a number of providers in 3 Midwestern hospitals who demonstrated that the language used when talking about treatment, active treatment, the option is phrased as required, but when discussing palliative care, the palliative care is presented as optional. Well, that reflects a real bias towards aggressive treatment. Now, I like that finding, but I have no idea how generalizable it is. That's true for a great deal of the literature in this area. So I will use the literature as a source of hypotheses and never as a conclusion. Now, the fact is that the operating guideline from most hospital staffs, first responders and ethics committee is, when in doubt, make the most reversible error. Hospitals would rather be sued for wrongful life than wrongful death. That means that they often err by doing more, rarely by doing less. That's fine if you want more, but not if your idea is for a less invasive treatment. One of the hats I wear is a helmet. I'm a first responder in a rural fire department. The protocol that I follow is when I arrive at scene, unless there's a compelling reason not to resuscitate, that is, the patient either is clearly dead and rigor mortis has set in, or there's a DNR, I am obliged to resuscitate. When you enter a Swedish hospital, you sign an agreement that you will receive full treatment unless you have specifically declined it. Unless the patient is receiving palliative or hospice care, organized medicine really is a juggernaut. Each move in and deeper into the healthcare delivery system brings an escalation in the intensity of care, at least a quarter of which has been found to be of low value and possibly also iatrogenic. Excessive medical care includes overdiagnosis and treatment of conditions that will never cause symptoms or death, overtreatment supported by limited evidence of benefit for specific conditions, use of treatments at excessive in complexity, duration, impact, or cost relative to alternative accepted standards, and use of treatments that are futile. This Medscape study really discouraged. I found immensely discouraging. What you see is that only 40% of cardiologists, 40% of oncologists, and only 27% of ED physicians said they would not use a treatment they considered futile. That means all the rest would consider offering a futile treatment. I find that really unnerving. If, again, it's generalizable. We pay dearly for this overtreatment. More than 20% of the Medicare budget is spent on fragmented, uncoordinated care for patients in their final year, 70% in the final month. U.S. healthcare expenses exceed all 33 countries in the Organization of Economic Cooperation and Development. It took up 25% of the American GDP in 2015, and is estimated to take up half by 2082. Out-of-pocket costs equate with 25% of the baseline total household assets of patients and 43% of the non-household assets. So we bankrupt 59% of the people. 59% of bankruptcies are highly related to unnecessary and unwanted care. And that money might be justifiable, but in 2002 it was found to account for 30,000 iatrogenic deaths. That number has since risen. Also, a great deal of staff burnout, moral and ethical distress, and low levels of patient and staff satisfaction. Why does it happen? A lot of people fear litigation, so it's a CYA process to overtest and overtreat. Some people adhere to traditional practice protocols, which may no longer apply. Some people attend to a narrow outcome and ignore systemic effects. I've seen a number of situations in which people very, very close to the end of their life will be given a pacemaker because the cardiologist believes that normalizing the pace of their heart will stabilize their condition. It will not. They're not going to die any slower with a pacemaker. In fact, they may die sooner because of iatrogenic effects of placing it. Many patients are overtreated because providers don't understand the immense power of palliative care, then have to admit it, there are economic incentives for institutions and providers. My now deceased 94-year-old father-in-law had serious Lewy body dementia, was dying. My mother-in-law was convinced by her provider to have a pacemaker put in. It was a $29,000 procedure. He lived 5 days with it. There was an economic incentive for doing it. Clearly, it was not in the patient's interest. I hate to say it, but sometimes that happens. And then it's inherent in the language that we use with patients, as I say. So why are we here? Patients often don't exercise their right to choose, and healthcare providers often don't provide it. Now we can start getting pragmatic. Sorry that intro took so long. I use two formats for advanced care planning. Optimally, I use thoughtful discussion about possible alternatives if I've got 45 to 90 minutes to do it. It helps patients develop a perspective about coping with dying and death, teaches them how to collect and evaluate information they'll need, facilitates completion of living wills that includes a statement of their values and preferences. For example, I use 6 steps, a CMO or a MOLI, and it's signed by the person authorized to enter those medical orders are signed by the person authorized to enter the medical order. And I also guide in the appointment and preparation of surrogates. Starting an advanced care process before it's needed provides a possibility for yearly reviews, which gives wonderful opportunities for healthcare promotion. Sometimes I have to do it in a crisis, and there's pressure because of a progressive life-threatening condition that demands immediate action. I can normally complete a CMO in 10 to 15 minutes with decision-capable patients. That helps patients stipulate their values and goals, draft a CMO or MOLI, and hopefully gives me a chance with the patient to inform the surrogate about what's needed. Now, all advanced care planning discussion should be private, free of distractions, unrushed, facilitative, non-judgmental, and should include major stakeholders if at all possible. Given the immense power of an advanced directive is greatly influenced by surrogates in promoting it, I think it's really important to line up surrogates who will do a good job of doing just that. Now, everybody isn't ready for advanced care planning. You have to make sure that the patient isn't delirious and the patient has the ability to maintain orientation. For example, is not distracted by intractable pain. It's important to make sure that depression is moderate and not severe, as is true for anxiety, because they too can preclude capable thinking. Patient also has to have enough executive ego function to perceive accurately and make good judgments and reason clearly. And there has to be relative freedom from social pressures. For example, some families say, you know, Pop, it's not up to you. It's up to us to decide how you're going to die. That's got to be neutralized in order to free the patient to make his or her own decisions. And then there's sometimes religious opposition to tampering with God's will. And we'll get to that in a few minutes also. Any of these factors may require attention before attempting advanced care planning. It's absolutely necessary to prepare. Please do not ever approach a patient to create a living will until you've completed your own, and ideally a CMO or a MOLI to go with it. I was astounded at how problematic I found it to be when I did it for myself. If possible, also help a relative or a friend create one. Unless you've had personal experience with doing the process, there's no way to do it effectively. And you also have to understand the nuances of the physical, psychological, social, and spiritual trajectories towards death. Death, as you know, is rarely linear, usually gradual, trending down with some short-term ups and downs. You have to acquire skills that you need to maintain equanimity in challenging clinical environment. If we're not calm, patients cannot possibly be. When my middle son was seriously ill in the Stanford ICU, we agreed that I had to be the person that went and spent the 11 days with him. My ex-wife couldn't because she was much too likely to go to pieces. Surrogates have really got to be able to control their emotions at highly evocative situations in order to do their job well. And you also have to learn the pros and cons of all the likely measures, including their treatment burden, their short and long-term effects, their role in the sequence of probable ensuing procedures. The paper on the CMO has an appendix which I use as a prompt sheet when I have to discuss resuscitation, oxygenation, and hydration and nutrition. I don't try to do it from memory. I keep the prompt sheet handy. I don't cover this all with every patient, but I cover enough of it so the patient will be informed. You have to include in the list, you're going to discuss it, things like antibiotics, surgery, and dialysis. Now, you need a point of view in order to be able to help patients effectively. And you've got to articulate your own belief. For me, there are 4 elements in coping with crises like dying. First one is luck. You need a certain amount of biological, situational, or socioeconomic, cultural good fortune. I'm 88. I've lived this long, not because I'm a wonderful person, but because biologically I escaped those genes which would have made me vulnerable to illnesses that could have ended my life much sooner. Next, you need radical acceptance. Unless you accept the fact that you have a serious illness, there is no way that you will cope with it effectively, and you will be overwhelmed by it, not on your terms, but on its. You also need social support. Nobody deals effectively with death and dying or critical illness without the support of at least one other person. And finally, you need solution versus emotion-focused coping. For about 40 years, I've been writing a book on surviving POW camps, gulags, concentration camps, and similar disempowering environments. The people that wrote about how badly they felt died early. The people who wrote about where they were going to get the next piece of bread or how they could get through the next hour were likely to survive. That's solution-focused coping, and it's absolutely essential. We can't offer luck, so we can teach risk reduction, but we can teach and reinforce radical acceptance, how to get social support, and how to use solution-focused coping. One problem that I run into a lot in wanting and starting discussions about advanced care planning, people say, well, they hope for the best. Well, hope is interesting. As a cognition, it's an expectation. I hope I'll wake up tomorrow. I expect I probably will. But hope is also an emotion. I have faith that I'll wake up tomorrow. Both are critical and radical acceptance. Cognition is needed in order to define the challenge, and and the emotion of hope is critical to accepting and acting on the definition and incorporating the outcome. But hope is like a drug. It's best taken in moderation or it becomes toxic. Hope can be life-enhancing. The Buddhist proverb says, the man who believes all roads lead to doom is surely doomed. We must have some optimism and try new things, but also be life-ending. The Chinese proverb says, the hungry man who stands with his mouth open, hoping that a roast duck will fly in, will die a hungry man. Many therapy patients want to continue failing treatments because they hope for a better outcome. It's necessary to help frame that in light of the cognitive aspects of hope, which is a realistic assessment of expectations. So when I help patients deal with hope, I try to broaden the concept beyond cure to include achieving meaning and closure in life as life draws to a close and meets its inevitable end. ACP is always goal-oriented. It must always show respect, concern, and patience with the patient. Sometimes I'm really kind of annoyed, thinking, oh, this person ought to know better. That's a dangerous emotion that I try to tramp on anytime it arises. It's important not to preach or cajole. Obviously, I believe everybody should have one, but not everybody wants one. And I've got to restrain my effort to come on too strong. ADs are purely voluntary, and patients have the right to decline them. It's important to break the ice. I try to say a few words about myself to humanize the process, but never about my end-of-life preferences. So I have no right to influence my patients with my preferences. So I begin by saying something. It was hard for me to do this alone. I hope I can make it easier for you. But then you have to begin to get to know your patient as a person. Never be prejudicial on the basis of age or any other characteristic. We'll get to that in a minute too. Because those often lead to condescension, and that will offend patients and automatically end the process. So get to know something about the patient so you can know this person as an individual, not the patient in 8E103B or the patient dying with glioblastoma. It's important for me to hear my patient say, well, my passion is golf. And that would allow me to use golf metaphors such as, okay, we've got to tee up your end-of-life care. So if you ask 2 or 3 questions at the beginning about the person, that will help tremendously to personalize the process. Again, in the COM paper, whoops, I keep hitting the wrong key, sorry. Oh, I see what happened. I dropped a slide. You will find in Appendix 1 of the COM paper a protocol that I use for as a guideline. I read it over before I start talking to a patient just to make sure I have the sequence in mind. Now, it's important to be prepared in advance to deal with some very likely issues. Many patients are skeptical about providers' motives when asked to complete ADs. They're afraid of being manipulated. I explained that if you enter a hospital that's predisposed to do everything without an AD, as in entering without an AD is equivalent to throwing the brake pedal out of the window when careening down a steep, winding mountain road. Your values and goals are the steering wheel. Your AD is the brake. You make yourself very vulnerable to the thing you fear most if you choose not to have an AD. Many patients believe that their doctor should make decisions because they don't feel competent to do so. I try to explain that their doctors are experts on the facts, but the patients are experts on their goals. So I try to help patients make a distinction between what's done, which is their choice, and how it's done, which is the doctor's choice. Many patients are apprehensive about committing to advanced directives because they see them as dichotomous decisions. I've done group AC planning workshops for many years, and I constantly ran into a stumbling block when people had to make the dichotomous choices like CPR or DNR. That's why I developed the contingent medical order form. Resistance fell to close to zero once that humanizing option was presented. Then you have to deal with the generalized phobia about dying and death. I think it's important not to hide in euphemisms like passing. Death is a stage in the cycle of life. I try to help people radically accept that fact. Patients often have a sense of powerlessness because they don't understand the language or the system metrics, words like odds ratio or polysyllabic drug names. What I try to say is, your voice is your power, and the ethics committee can help amplify it if necessary, and I or any provider will help explain the meaning of any term you don't understand. Incidentally, when you're working with men almost invariably say they do understand when we don't, so you have to be very careful to make sure that men do understand. Some patients believe that preferences, they have a preference to rely on divine intervention, and they don't want to resist God's will. My response to that is it's hard to know whether prolonging life with artificial means accepts or rejects God's will. Tell me, Mr. Patient or Ms. Patient, what's your thought about that? And then again, distrust of the medical system, often based on race and ethnicity. And what I try to explain is that the worst care is likely if patients ignore or conflict with their providers. Even if you're not sure about your provider, enter the system as if your provider were your friend and advocate. So I begin the process with reassurance, try to explain that decisions will influence their care only if they're very ill with a terminal illness and can't communicate. Again, making that clarification made compliance with the workshop process much more fluid. The decision, remind them that decisions can be changed at any time as long as they have capacity to do so, and explain that the CMO or the MOLI creates the flexibility so decisions will not be mechanical. There are lots of prompt questions that I can use. I'm not going to read the whole list for you. This is one of those lists that's available for you to download and use at your pleasure. But I often begin with, what do you think it's important for me to know about you as a person? If you asked me, I would say, it's important for you to know that I feel my life is meaningful as long as I connect meaningfully with my wife and my kids, and as long as I can do something that I hope will make a difference in the lives of others. Got to know that about me, because that drives a whole lot of the decisions that I subsequently make. Oh, sorry, I had misplaced. This is the slide I wanted earlier, and this is the protocol for presenting the CMO. Again, it's available for you to look at your pleasure. Our goal is to learn about and work within the spectrum of patients' beliefs as much as possible. But if a core belief is premised on false information, we've got to respectfully provide facts that conflict with truths that patients hold dear. And that's best done by questioning. For example, did you know that? Or what's your response to someone who ... There's a very useful tool for getting to know multicultural perspectives, which you can find at this site. Research on religious, racial, and ethical resistance is really fascinating. A review of 33 mostly weak studies in my favorite resource, which is up to date, found that non-white or ethnic groups generally lack knowledge of ADs and were less likely than whites to create and advance directives. African Americans were consistently found to prefer use of life support, distrusting the system that they fear would deny them adequate care. And Asians and Hispanics were more likely than other racial or ethnic groups to prefer family-centered decision-making. But variants within groups existed and were related to subcultural values and level of acculturation. So it's really important to avoid stereotypes in this area. Remember what you learned in Research 101. Nomothetic or group data sets describe group tendencies, but because members of groups differ in many ways, one cannot make idiographic or individual predictions from group data. Also, because so much of the data is flawed, lacking theory, relying on convenience samples, and using non-standards measures, its conclusions are at best hypotheses. So I strongly suggest using group data as guides to questions, but use the answers to which will reveal important characteristics of individuals. For example, if you tell me that a patient is Asian American, I want to know, is that Cambodian, Siberian, Japanese? Is it first, second, or third generation? Is it Buddhist, Taoist, Zoroastrian, or Christian, or atheist? Knowing somebody's group identity does not give nearly enough information to be helpful. Now, in order to have an advance directive, people have to have capacity. Capacity is a clinical determination. It is issue and time specific. Competence, on the other hand, is a property or characteristic of a person, and it requires judicial determination. The default assumption is that patients and surrogates have capacity to make informed decisions. You've got to check that out. So before deciding that patients lack capacity, make sure you've done your job. Did you provide the information that they need, or could you provide it in a way that's easier to understand? Simpler words, a different language. Could anyone else help with communication, like a family member, chaplain, or a translator? Are there times of day when the patient's understanding is better? For example, avoiding sundowning. And are there locations where the individual may feel more comfortable and less distracted? And does the patient have all the relevant information? Remember, we've got to provide diagnosis and prognosis, the nature and character of the contemplated treatment, treatment burden and risks of the treatment, prospect for success, place of the treatment in the sequence of interventions, and similar facts about each alternative treatment and the likely result if the patient refuses all treatment. For their part, patients have to be able to be aware of the fact that they're making a decision, recognize the facts needed and needed information, receive, recall, and comprehend information, communicate and digest preferences, foresee likely consequences, process data rationally, and make and sustain a decision. These abilities all depend on capacity, the four core factors of which are understanding, appreciation, that is, what's the personal significance, reasoning, how can I juxtapose the information in a meaningful way, and do I realize that a choice is to be made? Capacity relevant issues can occur both when new treatment requests are made, but also when attempting to modify or even continue existing treatments. Reminder, it's important that capacity of the patient and the surrogate should also be addressed. Remember, men are tricky because we try to look competent, whether we are or not in fact. So you have to take extra effort to verify men's understanding. True confession, my wife prefers to go to any medical encounter I have because she doesn't trust me to reveal the complete situation or to admit to not knowing what the doc says. Providers are prone to question capacity if patients refuse treatment that we believe are warranted. That may be correct, but patients may also lack capacity if they accept treatments that providers recommend. So we have to check it. Capacity is not decided by the content of the decision, it's the process. To verify a patient's understanding, ask what's wrong, what treatment's been proposed, what are the risks and possible complications, what alternative treatments have been proposed, and what are their risks and complications. What would be the consequences if you refuse treatment, and then please restate your goals. In a paper in the references, I offer the capacity protocol that Stephen and I developed, and there's a check sheet that I use to record capacity evaluations whenever I have to do an ethics committee review. Time permitting, I also try to put in a pitch for health literacy. I try to encourage patients to ask questions. What would this test tell us? And how would that information affect your treatment? Again, true confession, when I was diagnosed with prostate cancer, I had 12 biopsies, one of which was showed cancer. I was told to repeat the process, which I did. They were all clear. I went in smiling into my doc and say, well, I don't have cancer. He said, oh, yes, you do. We found that in the first series. I was too stupid to have asked, what will I learn by the second series? That's the kind of question we have to help our patients ask. Always ask about drug interactions for any new drug. Stephen Thielke has done wonderful work on showing how aging people suffer many iatrogenic effects because as they see multiple specialists, the specialists provide drugs that often interact adversely with others in the patient's regimen. Teach patients how to get the facts. For example, I tell them that Dr. Google is often right, but not always. It's always confident, but not always right. So when you do a Google search, skip the first hits, which say ad, and look for ones that that come from more reliable sources. Also realize that disease organizations are often front for drug and device manufacturers, and they're not a good source of information. Also, I advise patients to get a second opinion whenever they're advised to undertake a major procedure, and ideally to get that second opinion from a provider working at a different facility. I have seen a number of patients' lives saved when they went to a second provider and got a differing opinion. I advise patients not to choose the opinion that they like the most between the two, but analyze the reasoning and the data behind them, and if in doubt, get a third opinion. And then also never forget TINSTAFL. There's no such thing as a free lunch. The Test to Treat program, in which people were advised to go to their drugstore, take a COVID test, and then immediately begin treatment, omits the fact that the treatment results the test results may be specious, or the treatment may be completely conflictual with other things that are taking place. So TINSTAFL is important. Okay, finally, guidelines for creating an AD. An advanced directives helps people differentiate between basing their life on quantity as a core value or quality. Living wills help patients decide which forms of a living will to use. There are many, but most are vague and most are incomplete. At present, only 6 steps, the CMO and the MOLI, offer conditional orders and an access to a full range of options. 6 steps, and also all of my protocols, begin with helping patients clarify their values about what determines their meaning in life. For many people, body and soul are different, and many believe that the soul is freed at death to ascend to higher places, but that's not true for everybody. So it's important to get people to reflect on where they stand on the nature of spirituality. Step 1 in 6 steps helps ask people a number of questions, which can be simply scored in a way that helps them clarify whether their primary focus is on quantity versus quality of death. I then, step 2, ask people to write a personal statement. A meaningful life is one that has a sense of purpose that's significant according to some standard and makes coherent sense to the person. Finding that meaning is a primary motivational force in humans, as Viktor Frankl told us in Man's Search for Meaning. Personal statements help patients articulate the meaning of their lives, their values and treatment goals, their preferences, and the criteria for each scope of treatment. So now I want you to put your thinking caps on. You're a first responder like me. You arrive at this house. 55-year-old Harold's pulse stipulates no CPR because he wants to avoid the rigors of a prolonged and painful death. But while gardening, he was stung by 8 wasps and suffered anaphylactic shock, from which he will die if not resuscitated. What would you do? Would you follow would you do CPR? But wait a minute, his pulse says no CPR. Or would you let him die? What are the moral and ethical risks of ignoring his pulse or complying with it? Fact is, the pulse provided no meaningful guidance in this matter. So as you notice, the pulse says, do you want resuscitation or not resuscitation? Life is just not dichotomously that simple. So the pulse asks for, among the objections to the pulse, that asks for medical condition that may be unknown in advance, did not validate evaluation or validate capacity. It asks about additional orders, but with no structure. In fact, the Washington State Guide to the Pulse says that the pulse asks for 4 procedures, but in fact, if you'll notice, it only deals with resuscitation and nutrition and artificial hydration. It does not offer a whole blameless cause. A lot of people are reluctant to follow the order because they're afraid they'll get sued. Well, my forms all say, I won't hold you, I will hold you blameless if you follow my request. And as mentioned earlier, the order has a biased title. So it is essential from my point of view to use either the CMO or the MOLI, because they're the only ones that offer realistic choices. So as you can see, the MOLI says, I do want resuscitation at all times. I want resuscitation only if it will remedy a short-term condition, or I don't want resuscitation at any time. I've worked with patients who feel that their lives are spent, they're ready to die. If they happen to be stung by 8 wasps, they consider that a blessing and they want to die. That should be their choice. But I can't make that choice for them. So it's really important from my point of view to have trichotomous, not dichotomous orders. The same is true for the CMO. The CMO and the MOLI are both customizable forms. This is mine. I printed it and I made some personalized changes in it that fit my preferences, and but that eliminate the need for really problematic decisions by my providers or by my wife. So here's another example. Alex has a pulse, which says that he wants full treatment. Alex suffered a massive head trauma in a rock climbing incident and is believed to have lost control of all body functions, including the ability to communicate. He spent his life engaging in high-risk outdoor activities and often said that he goes nuts when he's away from the mountains for longer than a day or two. He has no pulse or respiration. Resuscitation would mean that he could spend days intubated, pegged, and catheterized, probably with restraints to prevent his reflexive removal of tubes. What would you do? Would you resuscitate him and doom him to that? Well, if you read his personal statement, he would say life is only valuable to him if he can be fully active in the great outdoors. The conditional order is necessary to provide a patient-friendly outcome. Or there's 75-year-old Martha. This was one of my patients, actually. Her pulse said she didn't want a CPR. She had just seen a PCP who prescribed a 4th SSRI to improve her sleep. Remember, many old people see multiple providers. They often don't read the entire record. So this last guy provided a 4th SSRI without realizing she was already taking, a 3rd, without realizing she was already taking 2 others. Her husband called 911 when she collapsed in the bathroom that evening. Seeing the pulse, what should I have done? Let her die as a result of an iatrogenic medical error, or resuscitate? Again, the pulse was valueless in this situation. Only the conditional order is necessary. So when I do 6 steps or the MOLI, I go through all of the options, and I won't fully discuss that process because it's articulated in the articles. Many patients say they want to die at home. So do I. But it's very different than the Norman Rockwell image. Incapacitating illnesses often require invasive management of bodily functions that undermine dignity, administration of technically challenging interventions, up to 24/7 continuous monitoring, exhausting physical assistance. People don't realize that they may not want their spouse 50 years to change their diapers. Caregivers often experience severe physical strain and fatigue. A wonderful book, The 36-Hour Day, characterizes that beautifully. Caregivers undergo profound emotional distress. They lose income because they've got to be there all the time. There's considerable expense if home health aides are needed. And then Medicare funding is woefully inadequate, despite the fact that home health care is so much cheaper than hospitalization. So, although many wish to die at home, the wish may be universal, but patients should be encouraged to consider the costs. Frankly, again, this is personal and it's irrelevant to my patients, but I would not want to put my wife through this burden. So patients should be informed about palliative care, of which I am a profound fan. It affirms living and dying as natural processes. It doesn't hasten or postpone death. It provides relief from distressing symptoms. It integrates physical, psychological, social, and spiritual dimensions of care, and it serves patients and their significant others very well, treats them as a functional system. Study of access to palliative care nationally and skilled nursing facilities found that compared to Caucasians, Blacks, and Hispanics were significantly less likely to be offered palliative care. And it's a particularly serious problem because Blacks were often admitted in more seriously deteriorated conditions. Sorry. So I take particular time to explain the nuances of palliative care to patients who are unfamiliar with it and to differentiate palliative from hospice care. And again, I won't go through these slides because you can read them more quickly than I can read them to you. Since about 50% of people alive today will die with dementia, I think it's also important in living wills to discuss dementia advance directives. Here's a sample of one of them in which patients are asked whether they want to live as long as they can with full effort, CPR, to receive treatment to prolong life, but DNR and DNI only to allow a peaceful death, or comfort only, controlling for pain, anxiety, breathlessness, and hospital care for comfort only, and under which dementia condition would they want each of those alternatives. I think it's really important to make that choice available. It's important to help people create a durable power of attorney for health. That is somebody to choose the treatment that you will receive. There is a lot of research to show that surrogates often do not understand what the dying patient wanted. So the people who are statutorily allowed to be decision makers are the patient, a court-appointed guardian, attorney in fact, or a DPOA, spouse or domestic partner, adult children, parents, or adult siblings. The following cannot be a DPOA: any of the physicians, employees of the physician, or owners of the facilities in which they're being treated. Because patients with dementia are at particular risk, even if there's a clear unwritten implication that primary decisions were made, families and healthcare by families and healthcare professionals rather than patients, it's important to make sure that the patient's voice was heard, particularly true when dementia is suspected. Sorry. Here is the 6 steps form for selecting a surrogate. When I do advanced care planning workshops, I ask people to come with their surrogate, and I asked the surrogate to say, what did you hear the patient request? If you were in my condition, what treatment would you choose? How do the choices you make differ from the ones I have made? Again, personally, my wife is very, very phobic about pain. I find pain somewhat interesting because I have a high pain threshold and experience very little of it. Barbara's afraid that if she gets seriously ill and says something hurts, I will say, well, let's study and make it interesting. And I'm afraid that if I say, oh, I have a toothache, that she'll say, well, off him. It's really important to help people differentiate between what they want and what the document creator wants. And then ask that I direct you to limit choices only to the terms in my AD, or do you have the right to present others? How would you respond if a provider or significant urged you to override my choices? I have been in the room when doc said, well, I understand you want to let your mother go, but when my mother was sick, this is what I chose. And that just enrages me. So I trained the patient to say, we're not treating your mother. We're trained the surrogate to say, we're not treating your mother, we're treating my mother. And this is what my mother wants. And then ask the patients to make sure they tell the surrogate anything they think is important. Now, the patient that got the third SSRI, a lot of docs today, in the interest of efficiency, medicate first and ask questions later, or forget to ask. So step 5 of 5 steps is the patient's best friend. Many providers have panels of 2,000 or more patients. They don't have time to do chart reviews. So by completing and regularly upgrading steps 5 and arriving at each session with a completed step 5, patients can make sure that they are known by the doc, and the doc will not prescribe a drug to which they have severe adverse reactions. They'll know what other conditions, they'll know what other providers. It's a 2-page form, and I asked every patient to have one and keep it current. So what have I tried to accomplish? Advanced care planning is for everyone. Another thing that really offends me about the Washington Pulse form, it says you should only have one when you're terminally ill. That's absurd. Young people who are critically injured and don't have a pulse, don't have an advanced directive, put themselves at the mercy of the medical system and may receive years or decades of treatment they don't want. Everybody should have an advanced care plan, beginning with all healthcare professionals. There was one right way to die for each patient today, but that may change tomorrow. So advanced care planning discussions have to be ongoing. Remember to ask who the patient is as a person, including values, goals, and how he or she would like to be remembered. Never forget that everyone is a unique culture and has an entirely individualized view of the elements of a good death. Tell the patients the facts, the diagnosis, and the prognosis, as well as it can be foretold, the pros and cons of what healthcare has to offer, balanced by careful attention to the patient's emotions. I don't ride over patient signs of distress, but address it. Ask what the patient would like to do based on the information and help clarify objectives in operational terms. Facilitate and mediate shared decision-making. I often, as I said, include surrogates in the process of creating the documents and often join in discussions with providers about how to implement them, and then advise the patient and significant others to do as much as possible to achieve important goals now before it's too late. So, given that you struggled through 79 slides, you're either very masochistic or you're interested in advanced care planning. At no charge, I would love to help you, your program, or your clinic develop and or deliver ACP services to diverse individuals or groups via staff development, consultation, or direct contact. For example, if you'd like, I'd be more than happy to facilitate Zoom-based advanced care workshops for your client population. If you're interested in that kind of help or have any questions, please contact me. Again, there's my email address. So mantras for today, 5 tests of dying. Say I'm sorry, say I forgive you, say thank you, say I love you, and say goodbye. And as Pablo Picasso said, only put off until tomorrow what you're willing to die having left undone. So that is my story. Barb, have I put you to sleep?
No, I was just waiting for you to go to that next slide.
Oh, okay. I'm sorry.
Do you want to talk a little bit about this one?
Okay. Well, these are the recommended readings. I paid to have unlimited access to the MOLI and the CMO papers. 6 Steps is a free online living will. It has a number of sidebars, which are each kind of mini statements about a variety of aspects of it. The protocol that Stephen and I developed for assessing patient capacity is downloadable. And then recently I published 3 blogs, 2 in Amateur's Guide to Death and Dying, and one just came out, on Sunday, and it's number 7. I can't scroll down to get it. Anyway, if you print the first 3 and the slides in green, you will have everything I think one needs to do a very effective job of delivering the service, which I cannot tell you how enriching it feels. I feel blessed when I have when somebody lets me in enough to help them think through how they want to end this phase of their life cycle.
So I don't see a lot of questions yet, but Julie is asking, how do we access your blog?
Oh, well, the links are all there. The 6 Steps Living Will, that's you've got the URL for that, and it has a wealth of information. I haven't updated it in about 8 months, and what I'm going to do for the next probably month or month and a half is do some refurbishing and some updating of that. Also, you can use that as a source of where other blog offerings will be published, or just write to me. I thrive on correspondence about advanced care planning. As you can tell, it's really a passion for me.
So Brenda is asking, how easy is it for first responders and others in the emergency sector to gain access to a person's wishes? Where is the best place for a person to store information for accessibility? Brenda's thinking about electronic health records and other places it can get lost in.
Excellent question. So I advise that people print their CMO or their MOLI on some colored paper and keep it with them. Most people put them in their safe deposit box, which is crazy. I ask people to make multiple copies. I have one in my glove compartment. Any doc I see has a copy. My wife, who is my surrogate, has a copy. You got to make it as available as possible. Even in Epic, there's a tab where you can put it, but ED docs don't necessarily have the time, and first responders like me often don't have the time to consult them. So I try to make them readily available. I thought that the question that she was going to ask is, how would a first responder or an ED doc know that the condition that created the heart or breathing stopping was reversible? The only way to know that is to talk to an observer. And so if I pull up to that woman who'd taken the 4th SSRI, and I didn't know that she had taken the 4th SSRI, I would have let her die. I needed her husband to tell me. Usually when there's a 911 call, it's not the patient who places it. It's somebody who on scene can tell them what happened. Accessibility of the document is a real challenge, and access to the information you need is a challenge, and it's far from a perfect process. Washington State used to have a registry for living wills, but they defunded it because it was too expensive. And I loved having it, but it was too hard to reach. And as a first responder, I'm not going to take out my phone or my laptop and try to reach a governmental agency. So by far the best thing to do is have this with you at all times, but don't tattoo it on your body. I've had ethics cases in which patients had DNR tattooed to their body, but you have no idea when that was put in and whether that was still their wishes. So this is an imperfect system, but without it, patients are unspeakably vulnerable.
I've actually seen people put it on their refrigerator.
That's wonderful. But if my patient, actually, I said my patient fell in the kitchen for disguise purposes, I obscured the fact that she actually fell at a wood pile in the backyard. So I would not have seen the pulse if it was on her refrigerator, though her husband had to have a copy of it. I want Barbara to have a copy of my CMO in her back pocket.
What is, oh, go ahead. Sorry.
So maximum, I mean, I would skywrite it. If it didn't vanish.
What is the next step if a person with dementia does not have the capacity to make end-of-life decisions, but does not see that?
Oh, that's really, really tricky. If the patient can't do it, the only possibility is to try to establish guardianship. And that can take 2 weeks. It's a legal process. There's some expense. That's why I advise everybody, as soon as they hear the words, to start creating a living will and include a dementia directive as part of it. Unfortunately, many people will wait too long to do it, and they will not have the capacity to rein in the juggernaut.
Do you have more information on providers who support palliative care?
What do you mean by more information?
I would imagine, is there a list of providers or a contact center or something like that?
The Overlake Hospital, for example, has a wonderful palliative care system. Swedish, in theory, has a palliative care department in each one of its units. And the way to access it would be to contact the ethics committee in each institution and ask them to direct you to the person most intimately involved in palliative care.
Norma is wondering if this kind of discussion would be appropriate within a senior center.
Absolutely. I've done them in senior centers. And I think it's usually important to do it there because most of those people still have capacity to make the decisions. I did a workshop in New York that had 279 people and their surrogates, and 90% walked out with completed documents. I've done them in retirement communities. I used to do it in person. Now, because of COVID, they tend to be Zoom activities. But if COVID ever gets controllable, I'm happy to start making the rounds again and do them in person.
Well, and Sharon has a question that sort of links with that. During COVID, with the difficulty getting witnesses or a notary, is the MOLI or the DPOA valid with none or just one witness?
Yes. First of all, it doesn't have to be notarized in the state of Washington, which is really very helpful. It's important to find out what the rules are in the state in which you are functional. But I have had difficulty getting people, helping people find witnesses. When I do workshops, any individual in the workshop can witness the other's documents. So that really facilitates that process very nicely. If I'm doing it with somebody remotely, I often think I'd have a neighbor come in for a minute. And that's all it takes. You don't need notarization. I recommend 2 witnesses, and that's only relevant is if somebody is gonna litigiously contest the decision. That's a rare situation, but I like to have people be defended against the unexpected.
And what are your thoughts about this discussion being facilitated by lay people?
Oh, lay people can certainly do it if they become well informed. Remember, I don't give medical information when I do this. I don't give medical advice. I don't tell people what procedure to use or not use. Lay people will be less able to ask questions, answer questions than a medical professional would. But that's what I meant when I said at the beginning, that you can't use facilitators to do this, but you've got to train facilitators, and they've got to learn how to base this on the patient's story rather than on a recitation of their own. And I'd be happy if anybody has a group of lay people that who want to facilitate. I'd be very happy to help them build the skills to do it.
And Tanya is wondering how or what are some positive ways for caretakers to address or discuss advanced directives with patients who have real high anxiety?
Well, I would say, first of all, you recognize the anxiety. I would say to a patient, I can see that you're really tense now and that things are really upsetting you. One of the explanations I say to patients about anxiety is not knowing where the road leads. So what I'd like to try to help you do is make some decisions about treatment so you know where the road is going. And that's going to help reduce your anxiety. There's a fair amount of literature that shows that actually doing advanced care planning reduces patients' depression about death because it makes it more comprehensible.
Any other questions? I don't see any popping up. There's just quite a few profound and heartfelt thank yous for this important information, Dr. Stewart. And I'll convey that information to you later.
Well, thank you
Mhm.
all for letting me go through this far too rapidly delivered spiel. But again, please contact me with questions or to invite my help with any aspect of it.
And you can certainly blame me for trying to keep it within the time frame.
Well, you did a wonderful job, Barb. The
All
audience
right.
would know that I started with 180 slides.
All right, everyone. Thank you so much, Dr. Stewart, and everyone. I will see you next week.
Thank you. Bye all.
Bye-bye.